Hello, and welcome to Precision Athletic Training Home Study CEUs. I am Megan Hunt, the Vice President of Precision Athletic Training, and I'm happy to have you logged on today. Precision Athletic Training provides quality and convenient athletic training services for sporting events. We were founded in 2009 and began providing CPR and CEU opportunities for athletic trainers in 2013. Please note that the course evaluation form and assessment form are posted on the same page as this video. Please remember to download them, fill them out, and email them to me at mhunt@precisionat.com. When I receive these, I can then email you your statement of credit for the course. If you have any questions, please email me or call me at 781-366-1880 during normal business hours. Our presenter for the Concussion series is Cassandra Johns. Cassie earned her undergraduate athletic training degree at Florida Southern College and her master's in science at Georgia Southern University, focusing on concussion research. Her thesis was focused on the prediction of concussion utilizing baseline assessment tools, which she presented on at NATA in St. Louis in 2015. Along with this, she's also the second author of The Role of a Certified Athletic Trainer/Therapist in Concussion Management, which is published in Current Research Concussion, a Canadian research journal. Without further ado, Cassandra Johns.
Hello everyone, and thank you for tuning into part 3 of our concussion lecture series. Today we'll be focusing on return to play and return to learn. As Megan said, my name is Cassandra Johns, and I'll be talking to you about all of this today, so let's get started. So just as a basic review, as we've learned in previous sessions, 1.6 to 3.8 million sports-related concussions occur annually. However, this number is likely higher since up to 70% go unreported, and the last time this was studied was 2006. There's a few different mechanisms for concussion. You could either have a direct blow, your whiplash effect, or any rotational or linear forces that could be causing the concussion. It's important to note, if you haven't tuned into the other lecture series, that most concussions actually occur without a direct blow to the head. The baseline assessment should include all the tools that you're using for your full post-injury assessment. So that should include a computerized neuropsychological exam, a neurocognitive exam such as SAC, a balance assessment, which could be BESS, a vision assessment where you could use King-Devick, and as we learned in the last lecture, even coaches or parents could administer this test with the proper training. And you should also have a graded symptom checklist to monitor where your athletes are at symptom-wise throughout the whole process. There are a few different problems with evaluation. We could be looking at an honesty issue. You might not recognize the injury immediately because they're not reporting them to you. And there's a practice effect with all of our exams. So, as I said kind of in the last lecture, you'll see in the research that once you sustain a concussion, balance actually improves within that 7 to 10 day period. And it's not that their balance is necessarily getting better, but you're having them perform the same exam every single day, they should improve. So that's actually one of the biggest issues with our evaluation method now, but it's also the only thing we have for evaluation methods are what we're using. So there's not much you can do about it other than use that multifaceted approach. Your common presentation is going to include any symptom on the graded symptom checklist, but most commonly headache, dizziness, nausea, blurred vision, light sensitivity, noise sensitivity. They could be experiencing post-traumatic amnesia, or they could also have experienced LOC or be experiencing LOC, which is loss of consciousness. As far as prediction goes, we know that if you have a history of concussion, you're at an increased risk of any subsequent concussion, from a 3 to 6 times greater risk. Lower extremity injury is also going to be related to concussion. Any mental health issues such as depression, anxiety, or personality disorders, and behavioral issues such as ADD and ADHD are going to increase a person's risk of sustaining a concussion. You could have an athlete who has prolonged recovery that doesn't recover within that 7 to 10 day period. Things that could predict this would be PTA, post-traumatic amnesia, or the migraine symptom cluster, or a history of a concussion, having a second concussion or a subsequent concussion before the first one fully healed or recovered. So what do we do now? We've identified the concussion, and their symptoms are starting to get better. So your initial eval is done and has been confirmed by a doctor, as it should be within that 24 to 48 hour mark, as recommended by the NITA position statement and the 4th International Consensus Statement. By the way, if I pause during this, I'm just having a sip of something to drink so I don't lose my voice during it, so just kind of bear with me with that. So now your athlete is back to baseline. So when they're back to baseline, you can start that return to play protocol, which we'll go in depth with later. It's kind of important to note, and I'm sure I'll get into this a little bit later, but most athletes aren't going to have a 0 baseline for their graded symptom checklist. So with that being said, if you don't have a baseline for them and everything else is back to normal, you might want to consult with the doctor and say, hey, they have a 1 out of 6 headache or a 1 out of 10 headache, however you're ranking it on your symptom scale, but everything else is back to normal. How do you want to proceed? Because they could always kind of have that 1 out of 6 or 1 out of 10 headache. That could be their normal or their baseline. They could be back to baseline and still having problems in school. If going to school is irritating their symptoms, then you want to be focusing more on the return to learn aspect, which we'll be getting into, versus the return to play aspect. You definitely want them back to school and back to normal everyday function as far as that goes before you worry about getting them back into sports. Once they're back at school, you can begin their return to play protocol, and return to play will be that protocol that we go over later, but it should be stepwise. So what are the consensus statement or position statement recommendations when it comes to return to learn? Return to learn should be managed in a stepwise program that fits the needs of the individual. Its guidelines should assume that both physical and cognitive activities require brain energy utilization, and they similarly assume that such brain injury is not available for physical and cognitive exertion because of the concussion-induced brain energy crisis. Return to learn recommendations are based on consensus statements with a positive evidence-based data to correlate with such consensus recommendations. Return to learn recommendations should be made with the context of a multidisciplinary team that includes physicians, athletic trainers, coaches, and administrators. And like return to play, it's not always easy to provide prescriptive recommendations for return to learn because the student athlete may appear physically normal but is unable to perform at his or her expected baseline due to concussive symptomology. So we're just going to backtrack back to that other slide to go over what the guidelines could be. So the NCAA came out with guidelines for collegiate athletes, which can be kind of mimicked for your high school athletes. So you're looking at a 30-minute interval approach. So their first day after diagnosis, they should be completely out of classes. Excuse me. So when they're completely out of classes, they should be resting at home. They shouldn't be watching TV. They shouldn't be doing anything that's going to increase or potentially increase the symptomology. After that, they should start returning in 30-minute intervals where they might do half of their class and kind of rest and relax for the other half as they start to progress back into play. Cognitive rest is as important, if not more important, than physical rest. You have to remember that this is a brain injury, and anything that your brain does is going to irritate the injury. So when somebody sprains their ankle, we tend to have them rest their ankle depending on the degree of the sprain. And you want to do the same thing with the brain. But this is definitely an individualized approach that should be a team approach as far as the athletic trainer, coaches, teachers, administrators. Sometimes you need to bring in a psychologist depending on how aggressive the symptoms are and how set back the athlete is. I had an athlete this fall who sustained a concussion in her second or third soccer game of the season. She still had symptoms in November, and she was still returning back to the classroom in November. At that point, her concussion specialist had her doing light exercise to try to get rid of the depressive state that she was in. She was also on a daily medication to try to help offset the symptoms that were occurring. But she definitely hadn't returned to play when I had left. I believe she might be back to basketball now. But again, these are things that you want to do as an individual approach. So what else are we looking at with return to learn? What are the obstacles that we're going to get at? So sometimes teachers aren't going to be as understanding, and I believe that that's more of a lack of education. Some teachers think that kids are milking their symptoms to get out of class, which could be the case for some kids. I mean, we can't speak for all athletes. We don't know what's going through their head. But a lot of the time that tends not to be the case. So when you're looking at your obstacles, your administrators and your teachers might not fully understand why this particular athlete can be in class, but they can't be taking tests. Or if they use iPads in class, which I know my athlete who suffered a concussion, they all had iPads in class. They can be in class, but they can't be using their iPad. So they're there just to listen because the iPad's increasing their symptoms. Stuff like that, sometimes teachers don't understand. And if it's something that's lasting for a long time, so if it's lasting more than a week or two, teachers tend to be slightly less understanding because they obviously want that student back in the classroom and actually learning. When I was at Georgia Southern, we had an athlete whose teachers weren't fully understanding why she wasn't able to participate in things, but she ended up having to medically withdraw from class because her concussion was that bad and she was essentially failing out because the system only allowed so much. You couldn't miss an entire semester and still kind of progress through. So sometimes you're looking at things like that where the athlete's just not getting better no matter what you do. And they really just need to withdraw themselves from school and figure out what they're doing next. That's definitely something you're going to see more in college than high school, but it does happen, unfortunately. So what else are we looking at? So the consensus statement and position statements recommend that once return to learn is done, then the athlete can return to play. And sometimes you'll see the models where return to learn and return to play happen simultaneously. That's not quite where we should be at. That backtracks a little bit on what the recommendations were. So it's important to stay up to date on what's happening within concussion research and how you're supposed to be dealing with these things, because unfortunately a lot of places are still doing this incorrectly. And it's a change that really needs to be implemented before something happens. So the Zurich guidelines, and we'll go over this before I pull up our return to play protocol that I kind of formulated for this lecture, is a progressive return to play. And this is from the third international consensus statement, but this part didn't change a whole lot, and it was a good chart, so I decided to use it. Your first stage should include no activity and complete cognitive rest with the objective of recovery. Your second stage should be light aerobic exercise, so walk, swim, stationary bike, just to increase the heart rate and see if that brings back symptoms. Obviously, the goal is that it doesn't. Step 3 would be sport-specific exercise, so any kind of moderate running in sports, no head impact activities. This is to get them back into the movement mode. And again, you want to make sure that they're not having symptoms while they're doing this. Then they're going to progress to non-contact training. So they're going to be doing more complex sport-specific drills. And it's to work on their exercise coordination and the use of their brain. And then they're going to go into full contact drills, followed by normal gameplay. So you'll see on the protocol that I'm about to show you that they should never be returning to full contact on game day. That should be something that they do in practice before they do it in a game. So let's look at these sample guidelines. So these are guidelines that I revised to hit some of the newer recommendations, but it was the protocol that I established when I was in grad school for the junior college I was working at. When I started working there, just to give you a little bit of a background, they had no protocols for anything. They had no emergency action plans. I mean, they were at the very beginning of a program. So one of my first responsibilities was to develop concussion management guidelines when I realized that they didn't have any. So this went through, it was mimicked off of Georgia Southern's protocol. It went through legal at the junior college and was approved and such. So some of the wording could be confusing at times, but it's what legal wanted. So if you're looking through it, or if this is something that you're going to save, it's going to be provided to you as a handout, then just kind of be aware of that. So Precision Athletic Training, as a disclaimer, has established sample protocols to care for student athletes who have sustained a concussion, which includes sideline assessment, symptom monitoring, balance and postural stability assessment, and neurocognitive assessment. As another disclaimer, this protocol is only a reference guide and should only be utilized as such. Precision Athletic Training assumes no liability for the use or misuse of this protocol. So the first bit of the guidelines were your preseason basic education guidelines. So when the athletes walk in the door, they should undergo basic education regarding the signs and symptoms of concussions, what to look for, and how to report them to the appropriate medical personnel. One of the things that I highlighted to my athletes when I was going over this is if I was not present at practice, because usually I had 4 practices going on at the same time, they were to report it to the coach and have somebody walk them up to the training room or come get me to go down to their practice. All student athletes were required to sign an agreement indicating that they would report any and all signs and/or symptoms of concussion to the appropriate medical personnel, and this agreement included basic educational materials in reference of concussions. They had to sign, date, and have a witness sign the agreement. This is to confirm that they have read these protocols, that they've read their basic education things, that they understood everything. And it was also a backup on us just in case something happened and they didn't report the concussion to us. So we had somebody that administered a preseason neuropsych exam called IMPACT. At this point, I hope that you guys all know what IMPACT is. If you don't, it's in part 2 of the lecture series, so if you haven't purchased that one, I go into pretty in-depth detail on impact, so you can look into that. Each student athlete had to undergo baseline testing of impact, SAC, and BESS, which are the most commonly utilized exams across the board. During the education portion of the meeting, we focused on concussion signs and symptoms, the NCAA or NJCAA, where I was, executive committee recommendations for concussion management. If you're at a high school, you should be looking at any of the high school recommendations for concussion management. We went through our concussion management guidelines and protocols, and we took any questions that any student athletes may have. So we met with each team individually, or I met with each team individually at the junior college to make sure that everybody understood stuff after the mini educational portions. They did the same thing at Georgia Southern. We also offered concussion education to coaches. I recommend that if you can't do a in-person seminar with your coaches, you offer something to your coaches as far as education goes, whether it's a webinar or a seminar or something. For purposes of this protocol, as a sample, we said that we could offer educational webinars or seminars to the clients that they could purchase for their coaching staff. We do not do that yet. So just as a disclaimer, that is not something that Precision Athletic Training has taken on at this point. But if we had, the education would include concussion signs and symptoms, NATA position statement recommendations. Any educational webinar stuff would include the most recent national and international recommendations. We would explain neurocognitive testing and how it's conducted as far as baseline and evaluation post-diagnosis. And we would take any questions that coaches may have, whether it was in person or via email. So what about diagnosis of concussion? For the purpose of this protocol, sports concussion was defined as a complex pathophysiological process affecting the brain, induced by traumatic biomechanical forces. Several common features that may be utilized in defining this included that a concussion may either be caused by a direct blow to the head, face, neck, or elsewhere on the body, with an impulsive force transmitted to the head. They typically result in a rapid onset of short-lived neurological impairment or function that resolves relatively spontaneously. The concussion may result in any neuropathological changes, but the acute clinical symptoms largely reflect a function disturbance rather than structural injury. Concussions result in a graded set of clinical syndromes that may or may not involve loss of consciousness. Resolution of the clinical and cognitive symptoms typically follow a sequential course, and a concussion is typically associated with grossly normal structural neuroimaging studies. So the reason why I read that to you is it's really important when you're going through with your coaches, especially if it's a coach that you don't work with all the time, that you can reiterate what a concussion is, how it happens, and why you're doing what you're doing with the athlete. I find that the more knowledgeable the coach finds you about the injury with any injury, the less they're going to argue with you, and that could just be my experience. But I've had really good luck with coaches when I sit down and explain stuff with them. To backtrack a little bit, I said in one of my other lectures, I had a baseball coach that I worked with who would say, you get hit in the head with a foul ball, it's normal. You're going to have dizziness, you're going to have a headache, you might have blurred vision, it goes away in a couple days, said and done. And I said, well, yeah, that's normal for a concussion. He goes, no, that's just normal. And we had to sit down and have the whole conversation of why it was a concussion and why it was concerning. And after that conversation, he was great about concussions, or at least pretended to be great about concussions. So we said that any concussion would be evaluated on site by us if we were there, and they would be referred to a physician for further evaluation. We recommended that the student athlete see the physician within 24 to 48 hours of injury. This window was developed in case the injury happened on a weekend. But if it happened on a Monday, we strongly urged the athletes to see a doctor the next day and I would strongly urge your athletes to see a doctor as soon as possible. They should not begin any return to play protocols until they have been diagnosed by a doctor and seen a doctor. So what could present when they get hit in the head? They could be unaware of the period, opposition, or score of the game. Those are the Maddox questions. There's a really great study about those if you ever want to read it. They could have confusion, amnesia, loss of consciousness, or they could be unaware of the date, time, or place. Your typical symptoms, as we've said before, could be headache, dizziness, nausea, loss of balance, feeling in a fog, having their bell rung, seeing stars or flashing lights, or double vision. They could be sleepy or feel like they're fatigued. Physical signs would be loss of consciousness, poor balance, any seizures or unsteadiness in gait. Slower to answer questions or follow directions. They could be easily distracted or poor concentration. This is a big one because if you have an athlete with ADD or ADHD, they could already be easily distracted and already have poor concentration. So you definitely want to follow through on that. They could be displaying inappropriate emotions, such as laughing or crying uncontrollably for seemingly no real reason. So that's something you want to dig into. Any nausea or vomiting, being glassy-eyed, slurred speech, or personality changes. Any inappropriate behavior, such as running in the wrong direction, or significantly decreased playing ability. So if you're not sure if they've had a concussion and all of a sudden they're playing kind of off, they're running in the wrong direction, they're being weird, you definitely want to pull that athlete out for further evaluation. So we went into diagnosis of concussion pretty significantly last lecture. This is something that I just want to touch upon as far as returning to play and evaluation go. I like to keep a little handout in my kit. It looks just like this. And on the bottom of it, it says it has a signature for the athlete and a signature for the parent. And it says that the student athlete will be referred to the emergency room, or 911 will be activated if the following occur. Obviously, inability to awaken the patient or unconsciousness or any suspicion of a C-spine, you're going to refer on site. But some of these other ones you might not, and it's important for the athlete and the parent to understand what would need to happen for them to have to go to the emergency room. So if they have a severe or worsening headache, I describe that as if you just have a headache that is really uncomfortable and all of a sudden you're like, oh, it feels like I just got hit by a bus. Maybe you should go get checked out, make sure you don't have anything else going on. Any disorientation or confusion that increases with time, drowsiness that increases with time, restlessness or unsteadiness that lasts longer than 15 minutes. So that's probably something that you're going to refer, but that could be a delayed onset symptom as well. Seizures that happen, obviously not in front of you. Difficulties with vision that last longer than 15 minutes. This is something else that can happen later on. So that's another thing that I reiterate to the parents. Vomiting, fever, or stiff neck, urinary bowel incontinence, which hopefully that's not happening. That's pretty uncommon with concussions, but it can happen. Or amnesia that lasts longer than 15 minutes. So the reason why I give this to the parent, and I say this when I give it to them, any sort of brain bleed is independent of the concussion itself. These are actually symptoms that would show a potential brain bleed. With that being said, brain bleeds are extraordinarily rare when it comes to concussions. We just want to be safe versus sorry and make sure that you're aware of the symptoms that your kid could be experiencing if this were to happen, and that you're able to take proper actions and quick actions to make sure that nothing else happens to them. So I definitely say more than once how rare it is that something like this could happen, but I want them to know what to look for in case it does. So now let's get into the return to play aspect of it. So we looked at things if the athlete was having signs and symptoms that were less than 30 minutes, we typically have them out, rested for 24 hours, and they must be asymptomatic at that point. All tests must be administered within 24 to 48 hours of injury, and they return to baseline scores. Sometimes they return to baseline scores the next day and they've been symptom-free for 24 hours. And usually it's the athletes that have the signs and symptoms lasting less than 30 minutes. But with this, they went through the entire protocol. And, protocol for day 1 through 7 is the same throughout, so I'm only going to go over this once. Again, you'll have the handout. We typically had them bike for 10 to 15 minutes on day 1. Day 2, they did the elliptical for 15 to 20 minutes and some light weightlifting prescribed by their athletic trainer for 20 minutes. Sometimes that was in conjunction with the strength coach, though. If they had lift that day, we would work with the strength coach so they could be lifting with their team. Day 3, we had them do the Stairmaster for 15 minutes and then exertional drills in a controlled environment. On day 4, they did a non-contact practice, usually 50 to 75% of practice, and then they did weightlifting with the team if they had weightlifting that day. Otherwise, we would work with the strength coach to make sure that they did something that they would normally be doing with the team. Day 5, they had a non-contact practice for 80 to 90% of practice, weightlifting and plyometrics. On day 6, they had a contact practice, but full co was not game day. And then day 7, they were released for full go activities. For anything lasting longer than 30 minutes, they were out on diagnosis day. They had a rest for 48 hours. All tests had to be administered again within that 24 to 48 hour mark of injury, and they had to return to baseline scores before starting this protocol. Again, they had to be asymptomatic throughout the whole protocol, or they went back to the step the day before. Once the concussion was determined by the step day protocol and it had begun, the team physician must have been seen and cleared the athlete to begin that protocol. All tests had to return to baseline reading. The student athlete must remain asymptomatic to advance to the next step in the protocol. If they advanced a step and began experiencing signs and symptoms, they had to discontinue all activities for the remainder of the day and regress back to the step of the previous day, the next day. If the student athlete remained asymptomatic throughout the protocol and was able to advance step day without complications, they must see the team physician prior to be released for full go status. That's important because sometimes in high school, the physician's just going to sign them off to return to play in the step. You might not see this in a high school protocol, but it's good to have some sort of communication with the physician if you can, following a concussion, just to make sure that they're on the same page with you throughout the stepwise protocol. I've had physicians, to kind of backtrack for 1 second, give a stepwise protocol that I was not comfortable with because it was a lot slower than what it was a lot faster than what I would usually use. So I had the athlete returning in, let's say, 3 days versus the 6 to 7, where the school I was at also had the 6 to 7 day protocol. So in those cases, I opted to use the school's protocol, which is a little bit more conservative, with the school's support on doing that. If symptoms returned after the protocol had begun, we referred the athlete to a physician. I would still do that at the high school level as well. And this just kind of goes through what we've already gone through. I'm not going to read you the whole protocol because that is something that you can do yourself. Another thing that I wanted to reiterate, or go over, I guess I should say, I haven't really talked about it yet, is Policy 5.0 and Policy 6.0. So for the second concussion of this season, if a student athlete with a documented concussion for this season was diagnosed with a second concussion in the same season or within 3 months of the previous concussion, the student athlete should be removed for twice the maximum amount of time. Rest for 1 week, can begin the step day protocol second week as long as they were asymptomatic. For the third concussion of the season, if a student athlete with 2 documented concussions for the season was diagnosed with a third concussion in the same season, the student athlete will be disqualified from competition for the remainder of that respective season. At that point, we also refer them to a concussion specialist to try to figure out why they were sustaining so many concussions. Okay, excuse me while I take a sip of my water. Okay, So what else are we looking at with this return to play protocol or return to learn protocol? What about post-concussion syndrome? How is treatment different for this? So this kind of goes back to the athlete that I was talking about earlier, where they may begin light activity before they're back to school. My undergraduate program director and our clinical coordinator worked with a couple athletes at a local high school in Florida that had sustained concussions and were experiencing post-concussion syndrome. So the one that's always stuck out in my head that we talked about, and it's because I was down there when it was happening, was this girl who played softball. She was on either day 3 or 4 of her return to play protocol. She was in the dugout for the game. She wasn't actually playing, and she had a foul ball tip off of her head. And boom, she had another concussion, and a year later still hadn't recovered from it. She had seen all sorts of specialists, had done this or that. My program director had read some sort of military study, and I don't remember the name of it, that looked at the use of gaming glasses for post-concussion syndrome in the military. And she said, well, I'm going to see if we can use these gaming glasses on this athlete and see if it makes it better. Gaming glasses are to stop you from having a headache when you're staring at a computer for 12 hours a day. I don't know how many of you game. I know I don't, but they sit in a dark room with a bright TV right in front of it all day long. I know I would get a headache from that. So that's kind of how the gaming glasses are designed. They have a yellow tinted lens, and one of the things that they're supposed to help do is decrease the transmission of fluorescent light, or alter the transmission of fluorescent light into your eyes. And if you've been in high schools, which I'm sure you all have, it's mostly fluorescent lighting throughout the high school. So they did a few studies on Do the Eyes Have It? They're great studies if you want to look them up. Those are the citations. But they gave this girl these glasses. And I mean, they're not the most stylish thing in the world, so that's hard for a high schooler to walk in and have to be wearing those. But she loved them. All of a sudden, she could get through the day at school. Her head wasn't pounding. Her symptoms were gone. She could get through all of her schoolwork. I mean, it was life-changing for her. And where she'll never return to sports, she does have a normal everyday life. I don't know if she's still wearing the glasses. It's been a couple years since I followed up with her or heard anything about her. She wasn't my particular athlete, so I don't know her details now, but the gaming glasses helped her a lot. I had an athlete this year who was talking about how she used the glasses last year when she had sustained a concussion because the classroom lights were bothering her and she was having trouble getting through her schoolwork. And when she got the gaming glasses, everything kind of fell into place for her and she was able to get through her schoolwork. It's kind of touchy if you're going to have an athlete that's using these and you're going to return them to play. That's definitely something you want to go over with the doctor. I know I wouldn't necessarily be comfortable with it, but if the doctor is and you can come up with some sort of a plan depending on the sport that they play, then that's great. But I recommended them to my post-concussion syndrome girl this year because I knew how much pain she was in when she was dealing with school. They are about $80. I know people have asked when I've done lectures in the past about those glasses, the night glasses that you see on TV. I haven't seen any studies about those, but the way the glass is tinted is different. The anti-glare isn't supposed to filter the fluorescent light the same way that the gaming glasses do. I've been trying to look into shooting glasses because I've had that question in the past as well, and I haven't found the same type of lens when I'm looking at them, but from the specs, I would assume that they might work about the same. If they have shooting glasses already, I don't think there's any harm in trying them, but if they're going to have to go buy glasses for this, then I would just have them buy the gaming glasses. The website that we used when they were doing the study was www.gunnar.com, and those glasses seem to work. I have no affiliation with Gunnar, just as a disclaimer. I just know that they happen to sell gaming glasses, and that's what they used in those studies. So you're starting to hear with concussions about cutting edge rehab techniques. You started to hear about it in about 2014. There was a lot of talk about it during convention this past summer. But what are they using for rehab? So they've started balance rehab, which is great, but just keep in mind that that's going to increase your practice effect on your balance tests if you're teaching the athlete balance kind of as a rehab technique. A lot of places are having athletes do light cardio activity, more so those ones that are your post-concussion syndrome, so the ones that have been symptomatic for a few weeks, and they're kind of hitting that depressive state because they want to return back to play. Light cardio activities such as like walking uphill on the treadmill or like a speed walk shouldn't be bothering them too much. As long as it's not increasing their symptoms, it should be okay. But again, please consult with the doctor before you let your athlete do that. They've been looking at eye tracking and Dynavision type stuff. I don't know how many of you tuned into the last lecture where I kind of went through the Dynavision, but the square of the Dynavision moves up and down. You're supposed to focus on this dot right here, and the athlete's supposed to hit the buttons that light up as they're focusing on that dot. If you have any questions about Dynavision, I can send you some links. They're really easy to find on YouTube if you want to watch a video and you didn't tune into part 2 of the series. But the whole thought process behind the rehab techniques with concussions is we rehab every other injury we deal with. If you have an athlete sprain their ankle, or you have an athlete tear their rotator cuff, or you have an athlete tear their meniscus, you're going to rehab them and get them better that way. And for whatever reason, we haven't started rehabbing concussions yet. And I get that we're still in the rest period, but when their symptoms aren't getting aggravated by what they're doing, it's not a bad idea. I know if you send your athlete to a concussion specialist in this general area, and it's somebody who has post-concussion syndrome, they're going to start working on rehab techniques with them. So it's just kind of important to be familiar with the fact that it's going on and to understand what they might be doing. Because concussions are a puzzle that we haven't solved yet. So when it comes down to it, we definitely want to keep putting those puzzle pieces in and seeing what works. So how many concussions, to kind of transition, is too many? We hear a lot about that magic number discussion where people say 3 concussions is too many. It's definitely a gray matter as far as concussions go. But the thought process at this point that the research seems to agree with is it's not necessarily your first, second, or third concussion that pops you up on the how many concussions is too many. But it is when the hit starts to be disproportional with the symptoms. So if you have somebody who lightly tapped their head on a door, for example, and all of a sudden they're experiencing concussion symptoms, and they've now been experiencing them for a few days, that's something that you might want to consider the medical disqualification with. But be aware that the medical disqualification should be, I believe, some sort of a team approach. I know not every doctor would agree with working with athletic trainers as far as concussions go because they're not used to working with athletic trainers. But a lot of concussion specialists in this area will work with you and figure out when your athlete is at the point of not possibly being medically disqualified. I think it just depends on the doctor that they're seeing and who you're working with and what kind of relationship you have with the athlete and the doctor and the family. It's definitely hard when an athlete hits that disqualification point. If they started to have multiple concussions, you might want to try to talk them into, if they're in a pretty heavy contact sport, be like, you've already had 6 concussions in your career, maybe consider not doing this anymore. But that's more of a professional recommendation versus a medical disqualification. The important part of this is there is no magic number at this point, just like there's no set position in football at this point that's going to put you at an increased risk of concussion. So your biggest thing, to recap, is the not proportional or the inverse relationship between the hit and the blow on whether you're having symptoms that make sense or symptoms that don't make sense. We can't just pull a number out of a hat and say, okay, you've had 3 concussions and we're done. That's not really how it is, especially when you think of it as a lot of athletes entering college have probably already had at least one, if not more. A lot of athletes entering college have had multiple concussions that have been undiagnosed as well. So those are definitely things that you want to keep in mind. So kind of in summary, Return to Learn should be a stepwise, progressive protocol. The most common recommendation is that 30-minute interval approach, where you do 30 minutes of class and then you might take a break and then 30 minutes of class later, progressing into a full day. They might start with half days of the 30-minute approach. They might just start with one class. It just depends on their symptoms and what that team approach is. And it definitely should be a team approach utilizing the administration, teachers, doctor, yourself. Sometimes you're going to want to bring in a psychologist if they're having a hard time with it to help with that return to learn, return to play process, so they can try to figure that out. Return to play should again be that stepwise protocol. The most common approach is that 6 to 7 day approach. And again, if they are asymptomatic when they start and say day 4, they're in their non-contact practice, they've started to experience symptoms, so they started to experience symptoms, you're going to keep them out for the rest of that day and go back to day 3 the next day. This can sometimes be hard to explain to coaches that they were potentially going to have this athlete back for the big game coming up, but now there's been a bump in the road in their return to play activity, and they might not be back for that big game. Coaches tend to have a hard time with that, so just make sure you're explaining that in the best way possible to avoid any crazy conflict. The athlete's going to have a lot of trouble with that concept as well, that they were doing well and now they're not. They have a hard time understanding all that. Whenever I have an athlete who's developed symptoms within that return to play protocol, I try to talk to them to figure out if something different happened that day as well. So maybe they had a really hard day in school, they had a lot of tests, maybe they bumped their head again and forgot to tell you about it because they didn't think anything of it. I've definitely had athletes do that where they're like, oh, yeah, I think I might have a second concussion, but I didn't want to say anything. And you kind of have to like pull that out of them, like, okay, well, now you're playing in the game because you've already returned to play, but you bumped your head today at school, you didn't tell anybody about it, and now you're having symptoms. Those are the things that you really want to try to catch early. Sometimes you can't. Sometimes athletes just don't tell you, and it didn't happen on the athletic field, so you couldn't have even seen it. Those are the things that you just want to kind of be aware of could happen, and check in with your athletes when stuff like that is coming up to you. Post-concussion syndrome is something that we're kind of seeing more and more of, I feel like, or maybe I'm just seeing more and more in my practice. But you're seeing those athletes who are symptomatic for months on end, and they're having trouble with the return to learn and return to play. I like to recommend that every post-concussion syndrome case goes to a sports psychologist, and I might be one of the few people that really recommends that. But athletes tend to identify themselves as being athletes. And I know that that sounds a little common sensey, like, oh, duh, of course they do. But all they see themselves as is athletes sometimes, especially at the collegiate level. They live, breathe, eat that sport. They pretty much live for the sport, and then all of a sudden they can't play. They tend to have a hard time with that. Sometimes you'll see their grades suffer, partially because of the concussion, partially because they are pretty distraught about what's going on. It doesn't hurt to send them to a sports psychologist. It's important to tell them if that's part of your treatment plan. There's no shame in going to the sports psychologist to kind of work through it and come up with a better plan. Sometimes the sports psychologist can be really helpful in their progressive treatment plan. They can be great for that team approach. So, I don't know, I'm a big fan of that, personally. Do the eyes have it? So going back to those glasses, if you're working with somebody and nothing else is happening, you might as well try them. There's no reason why you shouldn't. They're not going to hurt anything. And quite frankly, a month in, most athletes are going to be pretty much willing to try anything, regardless of how goofy they may look or how dorky they may feel. I know when I had an athlete try it one day, she's like, but I look like a giant dork. And I'm like, but your head doesn't hurt. So there's that. It's one of those things that all of a sudden they feel better. So they're going to joke and say that they feel like they look goofy, or it makes them feel uncomfortable because they stand out because they're wearing these gaudy yellow glasses, but it's getting rid of their symptoms. So, I don't know. I think it's always worth a try, especially if it's something like that. The rehab techniques are continuing to evolve, so that's something you want to keep an eye out for in the research. There's not a ton out right now in the research that you can look up, but I would be willing to bet in the next year or so we're going to see a lot of rehab studies, and we're going to see a slightly different approach in how we're going to be treating our concussions. As of right now, we don't really know when that concussion resolves. I have my old graduate director who was doing studies on gait analysis following a concussion and having them walk down this gait right path, and they would have to walk back and forth, and there was this whole protocol to it. But he was finding that weeks or months after we returned them to play, their gait still wasn't back to normal, and their gait's not something that you can rehab. So we could be returning athletes too soon, although we don't really know at this point, but that could be where the rehab falls in on. Maybe that's the missing puzzle piece on getting athletes back to play in somewhat of a safer manner, especially if you're working on that balance. I know we talked about lower extremity injury being at an increased risk following a concussion in the first lecture. If you're working on lower extremity rehab with them and lower extremity strengthening, that could be decreasing that risk and potentially saving you a lot of time down the road. So at this point, I know you can't ask any questions. I hope you enjoyed the lecture. If you do have any questions, please email me. You have a PDF of this PowerPoint, and it's on that. My email is Cassie with a K @precisionat.com. Please remember to fill out those evaluation forms that you need to fill out to get credit for the course, and get those back to Megan so you can get your statement of credit, and let us know if you have any questions at all, and we would be happy to try to get answers to them. Thank you.